Thank you for inviting me to talk today. It's a good opportunity for me to kind of give an update on some of the new guidelines involving chest pain evaluation and how cardiac CT fits into that, and also risk prevention and how calcium score fits into that, and how we stress testing is still very important, but now cardiac CT is such a integral part to our evaluation of patients with chest pain or just evaluating overall cardiac risk. So I have no financial disclosures. Forgot to put a slide in about that. But objectives today. So first, recognize clinical indications for coronary CT in the evaluation of chest pain, and also when to consider a coronary CT instead of a stress test, and also vice versa, when to do a stress test instead of a coronary CT. And then also, we'll talk about calcium score CT, how to use them in the context of ASCVD risk prevention, atherosclerotic cardiovascular disease prevention for patients. And we'll learn about other applications of cardiac CT, less commonly used cardiac applications for them, but stuff that you'll probably encounter. So first, we'll talk about coronary CT, then the calcium score, and then other cardiac CT applications. So jumping into coronary CT. So what's neat about coronary CT is that it's a full anatomical assessment of the coronary arteries. It's completely non-invasive. Just think of it like getting a heart cath, an invasive angiogram, but completely non-invasively. And we can do some cool post-processing stuff to show like how the anatomy is. We can go into the vessel itself, some 3D post-processing. Really neat, powerful tools that we have. What's also nice about it is that you can identify and characterize the plaque itself, which you definitely can't do with like an echo or a stress test, and also assess for coronary anomalies, also things you can't really see with the stress test. Now coronary CT, widely accessible. It's basically at any center you can think of now, any major center, non-invasive, and it's overall safe. Patients are usually reassured that they can get the same information as a heart cath without having to risk the bleeding complication at all. And also, of course, a high level of diagnostic accuracy. To understand where cardiac CT fits in to your evaluation of a patient with chest pain, you kind of have to understand the full spectrum of chest pain. At the very top, your highest risk patient, of course, is your acute coronary syndrome, ACS. Below that is your high risk patient. So somebody who might come in with unstable angina, or somebody who has known coronary disease and they're having symptoms that are pretty typical of what they've experienced before with a prior MI or requiring a stent. Those are patients that it'd be very reasonable just to go straight to an angiogram. But if they're kind of still in that high risk category, but maybe they don't have a troponin elevation, things seem overall kind of stable, you can do anatomic testing like a coronary CT, or functional testing, which is a stress test. And that also falls into the intermediate risk category there, where you can do anatomic or functional testing. Intermediate risk would just be patient with typical chest pain symptoms, or patients that have pre-existing cardiac risk factors, or diabetic, smokers, strong family history. And then the low risk category is your kind of younger patient with no cardiovascular risk factors. Then in that case, you can do reassurance, depending on kind of your clinical impression of that, or you can do additional testing that is safe, like maybe do a treadmill stress test, or maybe get a calcium score. And we'll talk about how calcium score also fits into the new chest pain guidelines. And if they're asymptomatic, please don't test them. So that would be a contraindication. So the latest chest pain guidelines that came out 2 years ago finally put coronary CTA like right at the top of how we evaluate our chest pain patients that aren't having a heart attack. So it's a high level of evidence A, as well as a recommendation, level 1, that intermediate or high risk patients with stable chest pain, no prior coronary disease. Coronary CTA is very helpful for the diagnosis of CAD and risk stratification, guiding treatment decisions. And then stress testing remains class 1 recommendation, but actually with a slightly lower level of evidence. You can still do your intermediate to high risk patients with stable chest pain, no CAD. You can do stress echo, your nuclear stress testing, stress MRI. And the reason why probably a lower level of evidence is that coronary CT is a full anatomic evaluation. And so you see the plaque exactly. The sensitivity and specificity of your stress testing modalities, whether it's echo, nuclear, or MRI, is only like between 80 and 90%. Okay, 90% on a good day. So you can still risk some false negatives. So that's why coronary CTA, if you need a test that's going to completely exclude coronary disease or rule in obstructive disease that would benefit them from going to a heart cath, it's a great test. But we'll kind of learn that not everybody's a candidate for coronary CT, and I'll get to that in a second. So you're probably wondering, like, well, why don't we stop doing stress tests? Well, there's still a big role for stress tests, and but coronary CT still is just very, very powerful tool for us. It has strong negative predictive value. It also has a comparative positive predictive value compared to alternative testing, and it's effective first line investigation at all level of disease prevalence. So going into more depth about what coronary CTA shows us, it's anatomic testing. Like I said before, you're not looking at ischemia necessarily, like if one area of the heart's not getting good perfusion from the coronary arteries. You can visualize and diagnose the extent and severity of non-obstructive as well as obstructive coronary disease. The way we report these, we report it as like normal vessels, no atherosclerosis, and then we use this. It's called the CAD-RADS system. It's just a convention that helps keep the reporting for coronary CT very uniform across the board. A minimal stenosis, which would be just non-obstructive, just some plaque that's not causing significant luminal narrowing, would be 1 to 24%. Mild stenosis would be 25 to 49%. By definition, stenosis less than 50% is not obstructive. That wouldn't benefit from a stent at all. And then you get into moderate stenosis, and that would be 50 to 69%. And that's kind of an area of uncertainty. Sometimes these lesions, with the intermediate ones, can be obstructive and flow limiting, and those would benefit from getting a stent. But sometimes they might not be. They might be non-obstructive. In the cath lab, we have tools that are able to delineate that. And thankfully now we have a new tool, more recent, called HeartFlow. Is one of the vendors for it, where we can actually determine the functional significance of that lesion using some post-processing techniques. We send it to the company and they send it back. I'll talk a little bit more about that in detail. And then a severe stenosis, we call a blockage over 70%. That usually needs a heart cath and a stent to that lesion, especially if they're symptomatic. And here is a video. Hopefully it plays. I took this from our own post-processing software. We can get a really neat 3D image. This is not used really to look for stenoses, but so helpful to get an idea of the anatomy, make sure it's not an anomalous coronary artery coming off where it's not supposed to. You can also see coronary artery bypass grafts where they come off the aorta, where they touch down. If you don't have like the op report to kind of guide you where the bypass grafts originate from and are actually going. And this can be also helpful for our cath lab guys, like when they go into the lab and they want to know where the bypass grafts are actually coming from when they try to engage them in the aorta. So it's a great tool just to give us kind of a layout. And here we have a curved linear projection of the left main or the left anterior descending coronary artery here. And then you can see here, there's this little cursor here, and pop over here, and this corresponds to this area in the proximal LAD, and this kind of cross section here is the lumen up here. Each like kind of bar, the red bar represents the lumen here, the yellow bar lumen here, and the green bar lumen here. And as you kind of drag this across the vessel, the computer can automatically tell us kind of the percentage of stenosis as you move it down the vessel. So you can kind of get an accurate calculation there. Sometimes it requires some fine tuning, like with the calcium and the blooming and everything. But we have just some neat tools that kind of make it accurate and painless to, if you have a lot of blockages, it would take forever to like kind of manually trace each one. So thankfully we have tools that kind of make it more streamlined and easy for us. This is actually same slide as before, but different image on the side here. I mentioned plaque characteristics. It's not just about stenoses or making sure they have non-obstructive disease versus obstructive disease. because a non-obstructed plaque can be very dangerous too. And what's neat about coronary CT that maybe a heart cath might not demonstrate is that you can visualize the plaque itself and characterize if it has some high risk features. For example, and those high risk features suggest that those patients are at high risk of that plaque kind of rupturing, causing a heart attack. Positive remodeling, meaning that the plaque is kind of forming on the edge of the vessel wall, but causing the external part of the vessel kind of bulge outward. That's a high risk finding. If the plaque is very low attenuating or dark appearing, that can be a sign that the imminent plaque rupture. Napkin ring sign tells us that there's this kind of in the plaque itself. This is the lumen or the artery, kind of where the blood flows flowing through, and then the cholesterol plaque is here. When you have this dark central part, that's actually necrotic core of the lipid plaque, and then it's surrounded by a non-necrotic core. Actually, that plaque's at risk of rupturing. So I always make sure to report these things like, hey, this is a 50% blockage, but that's an angry plaque and patient that could rupture at any time and cause a heart attack. So might not need a stent, but you definitely want to intensify their medical therapy and make sure that we're stabilizing that plaque. Another feature is spotty calcification. Usually see like kind of a dense calcification that accumulates over age along the walls of the artery. But when you have spots of calcium within the lipid plaque, that's another high risk finding. So when you read the report, we will, if we see these things, we'll report on that. We'll say in parentheses, high risk plaque finding. So we wouldn't expect you to like, no, like that's high risk. So, but hopefully just keep an eye out for those things when you read the report. And it's kind of another neat thing that a stress test would not tell us, right? Because a stress test will tell us if there's obstructive disease there, but won't tell us anything if there's non-obstructive disease or flow limiting things that, or non-flow limiting things there. So coronary CT is just really awesome and can show us a lot of different things about the condition of the coronary arteries. So let's think about an example here. So pretty typical scenario that I see. For example, a 37-year-old female with hypertension, cholesterol is pretty good, no diabetes, non-smoker, gets occasional exercise, BMI is 27, but she has this sharp left-sided chest pain, happens on a near daily basis. It's not necessarily predictable with activity. She might not have it when she's exercising. We do an EKG in the office, completely normal, but she's concerned because her father died of an MI at age 44. So understandably, she's very concerned and she's having these symptoms. What's going on with this? So you could either do a treadmill stress ECG, an exercise stress echo, a Lexiscan nuclear perfusion study, coronary CT, or you can reassure her and be like, okay, we'll just check your cholesterol next year. You can probably guess what the right answer is at this point in the talk. So yes, it's coronary CT. I'll tell you why the other ones wouldn't be a good option. So a treadmill stress ECG, the guidelines would suggest this is appropriate, especially the old guidelines, because this is overall on paper a low risk patient, but when we calculate our cardiovascular risk assessment, we don't always include the family history in our calculators. So you can say, let's just do a treadmill ECG, treadmill stress ECG, and make sure there's nothing there. But the sensitivity specificity of a treadmill stress ECG is actually pretty low, like 65%. So it's, it can be, you can do it for reassurance, but if that patient's still going to have symptoms, they're going to come back to you and be like, I'm still having this and I'm scared. So, and a treadmill stress ECG by itself is not a great way to kind of reassure them. Next is adding imaging to that, getting a treadmill stress test, but having a the echocardiogram images with it. That raises the sensitivity and specificity of the test, but still not as perfect as a coronary CT, because you can still have that risk for false negatives. The patient might still have symptoms that are like, should I do a heart cath? What should we do? So that the patient might not be satisfied with that either. And the physician might not be satisfied with that either. The next test is a Lexiscan nuclear perfusion study. The reason why that wouldn't be appropriate is because when a patient can exercise and do the treadmill stress test, it's contraindicated to do pharmacologic stress tests. Okay, so you need to have them exercising on the treadmill to get an accurate assessment of kind of what their workload, and it's also a more natural kind of physiologic response to, you get a more natural kind of physiologic interpretation of what their cardiac function is doing. So you want to do Lexa scan or pharmacological studies. So coronary CT would be the best test for this patient. And if it's normal and there's no plaque there, that's great. Like she'll be happy with that. That maybe the chest pain was not something really to be worried about. Maybe some musculoskeletal symptoms. Going deeper, stress test versus the cardiac CT or the coronary CTA. We first of all look at the pretest likelihood of coronary disease. When you're in that intermediate to high category, you can either choose stress testing or coronary CT. If they're low risk, you can do no testing, but it really, if they're having kind of typical symptoms or they have family history, I disagree with that you should really like investigate that and make sure that we're not missing something there. But choosing between kind of a stress test versus a cardiac CT, a younger patient would benefit best from a coronary CT, and an older patient, kind of above 65 years of age, would be best suited by starting with a stress test. And the reason why is because when you're elderly, like as you age, your plaque in your coronary arteries is going to harden and calcify. And if you have extensive calcific burden in your coronary arteries, that creates a lot of bright blooming artifact, and that can make a blockage feel or look more narrow than it actually is. It can overestimate the severity of a blockage, lead maybe to an inappropriate heart cath. The patient has a complication from that. So whenever I see like an 80-year-old patient coming through with a coronary CT, I'm like, oh no, like I really hope this does not result in an inappropriate heart cath. So these sort of patients are best favored by an ischemic driven evaluation, which would be doing a stress test, not doing an anatomic evaluation. But if they're younger, they're going to have maybe some scattered calcific plaque. It'll be easily interpretable with a high level of accuracy. So those patients, coronary CT, great idea for them, but just kind of be careful about the patients you refer if they're elderly, because you might end up sending them inappropriately to a heart cath. So if some scenarios that might favor use of a coronary CT, if you absolutely want to rule out obstructive coronary disease, of course, this is a great way. But the benefit of coronary CT, as I mentioned before, you can detect non-obstructive coronary disease. What favors the use of stress testing, like Lexa scan nuclear test or stress echo, is ischemia guided management. So preoperative testing, the evidence that we use to guide us in saying a patient is low, intermediate, or high risk before going to a non-cardiac surgery is based on kind of the ischemic burden of the heart, or the percentage of the myocardium that is ischemic or not getting good blood flow. And we can only find that out with a stress test. Coronary CT does not provide that information. So coronary CT is not recommended for like a surgical evaluation if you feel like we need to exclude significant ischemia before they go in for their non-cardiac surgery. So there's still a great role for stress testing there. And then kind of the age cutoff too, 65 years old favors the use, younger than 65 favors the use of coronary CT, above 65 favors the use of stress testing. If the patient had like kind of an equivocal prior stress test or uncertain results or persistent symptoms despite kind of a normal exam, doing a coronary CT is a great way to get a definitive look at things. Or if on the flip side, you can do a stress test if your cardiac CT wasn't conclusive, or you felt like there's a lot of calcium there that overestimated the presence of plaque, and you don't want to quite send them to a heart cath. So let's see if those lesions are ischemic and do a stress test. And then you can check also for anomalous coronary arteries. You can also see the aorta and the pulmonary arteries very well. And then another scenario that might favor use of stress testing, if you think that patient has a massive old heart attack and you want to see the extent of the scar that's present, a Lexa scan stress test can show that, as well a nuclear stress test or cardiac MRI or an echocardiogram. Or if there's coronary microvascular dysfunction, like a patient has normal coronary arteries, and you want to see if it's microvascular problem when their epicardial coronary arteries are normal, you can do a PET stress test or a cardiac MRI adenosine stress test. So, okay, another scenario. So, 72-year-old male with a history of hypertension, hyperlipidemia, smoked in the past, but it's been like 20 years, previously a pack-a-day smoker, non-diabetic, presents with substernal chest discomfort that's infrequently occurring with activity. Some things like exercise, like when he does a brisk walk at the gym, doesn't really cause any issues, but when he goes up a flight of stairs, he might have some chest pressure. ECG in the office shows left bundle branch block, which is known, not a new finding. He had a cath 10 years prior when he had chest pain at that time, and that showed non-obstructive coronary disease, so had some plaque at the time. But no functional limitations. He enjoys brisk walks at an incline on the treadmill most days of the week when he goes to the gym. So, which test would you do now after what we learned from before? So, what's that? Newcomb. Close. Okay. So the patient can exercise. So we don't want to nuke them. Okay. So no Lexus scan. I mean, you could do an exercise nuclear stress test. That would work, but not a Lexus scan. So that's why I didn't put that as an option, exercise nuclear stress test. So you're close. No coronary CT because the patient, his last cath already showed a bunch of plaque. He's above the age of 65. And I'd just be concerned that we start with a coronary CT and it might overestimate the presence of plaque because of all the calcium that's there. And so that might lead to an unnecessary heart cath. So the right answer would be an exercise stress echo to start. Okay, so let's talk about the obstacles to a coronary CT. Because in a perfect world, everybody would get a coronary CT because it's a 1A recommendation for every patient with stress test or chest pain to get that. Well, like with any CT, if you have an allergy to contrast, okay, that needs to be pre-treated, not like a contraindication in getting one, but you need to jump through some hoops to get them safely scanned. If the patient can't breath hold or they're kind of altered and can't cooperate with the text instructions for them, then we're going to get a non-diagnostic scan. If they suddenly take a breath when we're getting the images, that's going to be non-diagnostic. It's just going to be a blurry mess, uninterpretable. If they're having acute respiratory distress or hypotension, unstable arrhythmia, the reason why that would be inappropriate to scan them in kind of an acute setting like that is because we use beta blockers to get their heart rate down to get good images. So if they're in respiratory distress, that might cause more like bronchospasm. If they're hypotensive, we give the patients a nitro below their tongue to dilate their coronary arteries right before the test. And that'll just make them more hypotensive. So that's another reason not to do it. Or if they have an unstable arrhythmia, of course, like if they're having a lot of PVCs or NSVT or AFib, then that might lead to a non-diagnostic scan because this really relies on a regular rhythm. Because if you have like a skip beat coming in early while you're acquiring the image, that might create major motion artifact. So a very regular rhythm is really important to get a good diagnostic study. Renal impairment, because this requires contrast. So you want to be careful about who you send. In those patients, it'd still be safe to do like a stress test, a nuke. If they can't get a beta blocker to get their heart rate down and we don't have any other alternative medications, maybe they have like an allergy to calcium channel blockers, or we don't have any ivabradine available, then in that case, the patient would not be a good candidate because we really got to get their heart rate down between 55 to 60 beats per minute to really get a diagnostic study. The heart rate variability and arrhythmia I mentioned before, or if they are unable to tolerate a nitroglycerin due to blood pressure or other reasons. So these are the potential scenarios where you might consider doing a stress test, or if they're acutely ill, then maybe you want to consider doing a heart cath in that situation as well. The other obstacle to coronary CT is that it's a high resolution CT scan. It blasts you with radiation, just like a nuclear stress test does. But I think that's an important thing to consider, especially if you're going to scan a younger person. Make sure they're aware, like, hey, if you're planning on having a ton of CTs for other reasons, maybe this would not be a great test to do right now in like your 30s or your upper 20s. To give you an idea, where cardiac CT kind of falls into the spectrum of things. Chest X-ray in millisieverts, very, very small radiation dose, very, very safe. If you do a diagnostic heart cath, that's 7 millisieverts. If you do put a stent in, the average radiation goes up to 17. So that's quite a bit of radiation. Sometimes it can be even higher if you have a complex intervention. Cardiac CT depends kind of on what protocol you're doing. If you're doing this prospective ECG triggering, this just means that when the machine is brilliant enough to just capture a part between each heartbeat, just one small phase between each heartbeat. So it's not scanning the entire like 1 second that between each heartbeat. So that helps reduce the radiation. When we say retrospective ECG gating, it means it's scanned through the entire cardiac cycle, like blasting them with radiation between each heartbeat. So we do that for patients like maybe a TAVR evaluation, where we want to see the aortic valve opening, during systole and diastole. But that's a lot of radiation. So you don't really want to do that for your younger people at all. And the nuclear imaging actually gives you a lot of radiation as well. We don't really do the dual isotope testing anymore, but we do the rest stress technetium scan here. That's 11 millisieverts. So that's actually more than a coronary CT. So keep that in mind. That it makes me so nervous when I see cardiologists out in the community that do Lexiscan stress tests each year. It's like, oh my gosh, it's like way more radiation than they need for like a not great diagnostic study. So if you see that and it being done, maybe call them out like, hey, maybe they need a stress echo instead if you're going to do it each year. So yeah, nuclear imaging has more radiation exposure than you'd expect. So within the spectrum of things, coronary CT is actually pretty safe. And this also just helps give you a context like, okay, maybe you are getting nuclear stress tests. What's the real world risk of that? Well, the risk of getting cancer from radiation received at imaging is really uncommon. Okay, 1 in 2,000. And then compared to the risk of death from heart disease, cancer, stroke, of course, these things are way more prevalent, but it's still a real concern. You want to be prudent with who, or when, and to whom you are administering a radiation exposing test. So heart rate modulation, when you're ordering these tests, it's a great help if you keep in mind when you place the order as an outpatient, what their resting heart rate is in the office. If they're going 90 to 100 beats per minute, they're going to come for the scan. We're going to have to reschedule it because we can give them some IV metoprolol, but the likelihood that we'll be able to get them slowed down to less than 60 beats per minute is kind of unlikely. So the best way to achieve good heart rate control, again, their heart rate below about 55 to 60 beats per minute, is to give them some metoprolol tartrate the night before morning of the test. I usually recommend 50 milligrams is pretty safe. Or you can give a higher dose if they have a really high heart rate. You can give 100 the night before and morning of. But that just helps them come in with kind of a better resting heart rate. Maybe they're 70 beats per minute. Maybe just need a couple of doses of IV metoprolol, get their heart rate perfectly down. And even if the patient's resting heart rate is at 60 beats per minute, if they're kind of an anxious person, you might still give them a little beta blocker to give them the morning of. I sometimes do that because when you give that nitro pill to dilate their coronary arteries, when we do the scan, they can sometimes have a reflex tachycardia that gets their heart rate up. So if they go in without any beta blocker on board at all, the second you acquire the images, their heart rate could spike up to 70 and reduce the diagnostic accuracy of the test. So FFRCT. So this is a really neat tool. I briefly mentioned this before. So we use this in our patients with those intermediate blockages, 50 to 70% of the cardiac CT, where that could be obstructive, could be non-obstructive. Might benefit from a stent, might be causing their symptoms, or it could be not flow limiting at all. We just need to intensify the medical therapy to prevent that from getting worse. So what in the cath lab we do with these intermediate lesions, we put a pressure wire across that lesion, and we measure the pressure difference distal to the lesion and proximal to it, and you get a ratio. If that ratio is less than 0.8, then that is flow limiting and they benefit from getting a stent because that's ischemic. With FFRCT, we get that same information, but non-invasively and very accurately. It's been compared head to head against patients getting heart cath and FFR, and it's been very miraculous because patients who come to you with a coronary CT, those patients previously that were getting those intermediate blockages, 50, 70%, you didn't really have a choice but to send it for a heart cath or maybe do another stress test to see if that lesion is functionally significant or not. But now we can do more processing. We send it to the company HeartFlow, and they process it. They put it through their magical machine learning algorithm, and it pumps this back to us. It kind of analyzes the flow dynamics of the contrast as it goes down the arteries. That's my simplest way of explaining it. And they can give us the map of each coronary artery and where it might be ischemic. So at each level, it gives us the ratio. So up here in the proximal LAD is 0.92, go down is 0.85 here. And as you get to distal LAD, it gets to 0.76, but I would still not consider that ischemic because that's at the very distal part. So, but if you saw like a 0.76 right at the proximal LAD, that'd be a hemodynamically significant blockage. And this is just a slide showing the range of values that we use. Normal is above 0.8, less than 0.75 is for sure abnormal. There's a little uncertainty between 0.75 and, or sorry, 0.76 and 0.8. That could go either way. But at that case, I would think about their symptoms, and if they're very symptomatic, high suspicion that that's ischemic, send them to a heart cath. And also, if you have a bunch of lesions in, kind of in sequence, and at the top it's like 0.9, then goes to 0.8, then it's 0.65. You look at the difference between the lesions. Like before, it might be 0.8, but if it goes down to 0.65 after that, greater than 0.12 indicates lesion-specific ischemia. So you have to kind of subtract the FFR values as you go down the vessel. Okay. So a couple examples. So 66-year-old male he has a moderate 50 to 70% proximal LAD stenosis right here. Uncertain if that's hemodynamically significant. So you send it for HeartFlow FFR CT, and you get 0.72, and that suggests hemodynamic significance. Also, the delta, meaning what the FFR value proximal to the lesion, and the step down after the lesion was 0.18, greater than 0.12 is significant. So send this patient for a coronary angiogram for consideration of a stent. And let's see here. Okay. Another example. This is kind of a similar scenario. A 67-year-old male with moderate mid-LAD, 50 to 70% stenosis. Looks scary on the CT scan. And then the cross-section here definitely looks kind of intermediate, calcified. But you send it for FFR CT, and it's 0.92. And that suggests that it's not hemodynamically significant. So you just intensify their statin and put them on an aspirin to prevent that from getting worse. Okay, and another one, a positive one, 50%, 70% stenosis, big step down in their FFR. You can see it's always color-coded. Red is bad. Going from blue to red would be very bad. So invasive angiography here showed a severe LAD stenosis, very tight there, got a stent, patient did well. You can also do coronary CT as an inpatient study. I usually think of it more as an outpatient study, but if a patient comes in and the ACS is ruled out overnight and you want to get a definitive test that'll exclude obstructive coronary disease, you can definitely do it as an inpatient. It's kind of tricky to do as an inpatient because a lot of times their heart rate's elevated, just kind of the nature of being in the hospital. Your heart rate might be a little elevated. So you will definitely have to give some beta blocker, get their heart rate down. We've already talked about the advantages of doing coronary CT over a stress test, and it's the same in the inpatient setting. And also you can discharge with confidence that you don't have a false negative test. And that can be really powerful. Like your coronary CT was normal and the patient should be reassured by that. Like doing a heart cath in this case is not going to benefit you at all. So I think that could help patients like not get risk getting readmitted for another chest pain rule out. But the main obstacle, of course, is getting a good quality CT. Requires a heart rate of about 60 beats per minute, and that can sometimes lead to discharge delays. Like you decide in the morning after they get admitted that you want to do a coronary CT. Well, their heart rate's 90 beats per minute. You give them low pressure that morning, and 4 hours later, it's still high heart rate. And so you give them another dose, and then it's like 5 o'clock when they're ready, and then maybe we're not doing the scanning the coronaries at that time. Then they stay another day. So you have to be kind of thinking about what the likelihood you can get their heart rate down is before you order that in inpatient study. And of course, renal dysfunction is something you want to consider too. Not an issue with nuclear stress testing or stress echo. That can be done in a pinch. If you just want to get the patient out of the hospital and safely exclude significant obstructive disease, still very reasonable to do a stress test. Another application of coronary CT is bypass graft assessment. So if they've had a cabbage, we can assess them very accurately with coronary CT. I think, well, as a fellow, I did not like it when people sent bypass graft patients to the cath lab, because then we got to fish for them and everything. I wonder if my interventional colleagues feel the same now. But this is a good way to assess the grafts, like if they've gone down, where they're located, if there's any stenosis within it, before we send them for an invasive evaluation, before we give them a ton of radiation, because they're searching around for the origins of each bypass graft. Also, you can get a 3D image and see where they touch down and where they originate from, and that's always very helpful. And here's a surprisingly accurate description of coronary artery bypass grafting.
Tiny aorta fairies will take Mr. Legvein on a long trip to get married to Princess Left Ventricle.
Dad, are you trying to tell us you're getting a
So he's
car?
saying you
I
take
can't.
the leg vein and take a long journey up to Mr. Aorta. So, so surprisingly accurate. And I was thinking we should get our surgeons some finger puppets. I think that would maybe increase our patient
Tiny
satisfaction
aorta
for
fairies.
sure. All right, cardiac risk level assessment. This is what you want to consider whenever you're choosing your test. So if a patient's low risk, that would be your 30 to 39-year-old patient who presents with chest pain. The chest pain might not be typical. They're falling into that low risk category. In those patients, you want to consider doing a test that would safely kind of exclude coronary disease without exposing them to a ton of radiation. In this case, actually, calcium score would be really helpful. But when you get into that intermediate risk category, then you want to consider more detailed testing like stress testing, as well as coronary CT. So how are we doing on time? Okay, I should probably keep moving. So, all right, so let's move on to calcium score. Calcium score, very popular test now. I'm seeing a ton of them ordered. We're scanning a ton of them, which is great. I think it's a wonderful test, and because it adds additional risk stratification information for patients with uncertain cardiac risk, because it's all about prevention now, stopping severe coronary disease from developing before they reach the cath lab. So it's a non-contrast CT, so it's not as dependent on your heart rate, or you don't get IV contrast, so it's not like a coronary CTA. You can also diagnose subclinical coronary artery disease, the presence of the plaque itself, and you can also quantify the amount of plaque in the distribution, and that can give you a risk factor, or you can use that integrated with your risk factor calculator and give you an accurate 10-year assessment of their risk of sudden cardiac death or a cardiac event over the next 10 years. Also, if you send a patient and they get a calcium score of 0, incredibly powerful predictor of low risk for cardiac events over the next 10 to 15 years. So that can be also a very helpful tool in itself. And this also can be used to guide the initiation of statin or aspirin therapy. So some of my patients always ask or come to me concerned, how do I get the calcium? Do you need to check a lab value? Like, what's the calcium in my bloodstream? Is like, no, your plaque starts off kind of soft, mushy, inflamed, but as that plaque heals over time, you inevitably form kind of this calcified surface to it. So it's just the natural progression of a plaque as it heals over time. We're all going to have some plaque in our arteries. That's why our percentiles show, like, if you have a calcium score of like 10 to 20, but you're 70 years old and you're a guy, that's actually probably very low percentile, because most people your age group are going to have some calcium. But if you're 30 years old and you have a calcium score of 10, that's very abnormal. So that's going to be way higher than your peers. So I think the most helpful thing with calcium score is figuring out when it's appropriate and how to use the results. So that's what I wanted to focus on today with that. So think about a 41-year-old Caucasian female, no personal cardiac history, normal blood pressure, not diabetic, but she's concerned about her personal cardiac risk given her father had an MI at age 45. Primary care doctor appropriately checked her cholesterol, and it's pretty good. It fits within normal limits. Total cholesterol is less than 200, it's 181. Triglycerides are normal, 141. HDL is high at 53. Her LDL is 100. Our lab says less than 130 is normal. So technically normal value. And there's the 10-year risk calculator that we all use, or primary care doctors use as well. You put in all this information, their age, their sex, race, their blood pressure, their cholesterol numbers, history of diabetes, smoker, hypertension, if they're on statin or aspirin already. And that pumps out a 10-year cardiovascular risk assessment. The kind of the thresholds we use is less than 5% is low risk. You don't need a statin, those people, and even if their cholesterol is mildly elevated. Between 5 to 7.5% is as borderline risk, and there's uncertainty if that patient would benefit from a statin. In those patients, a calcium score is really helpful to decide if you want to start a statin or not. And between 7.5 and 20%, that's considered intermediate risk, and those patients benefit from being started on moderate or high intensity statin. And then about 20% is high risk for coronary disease, and they should be on a high intensity statin. So we plug all this information for this patient into this risk calculator assessment, and she's low risk, 0.5%. But her family history is not included in the assessment, and the patient's going to go home and feel like, okay, the calculator said I'm okay, my cholesterol and blood pressure is great, but I'm scared to death. Is this in my future? Am I going to follow my father's footstep? Well, calcium score is very appropriate to do in this situation. When a patient is low risk, sure, like she is, you can talk about risk discussion, emphasize lifestyle to reduce risk factors. But the radiation that you're exposed to with the calcium score is so low, it's an inexpensive test for a patient. We make it affordable. It's $99 out of pocket, cash pay, to get a calcium score done. And if the calcium score is 0, again, that's a very powerful predictor for low cardiac events over the next 10 to 15 years. If she was intermediate or borderline risk, then there's that uncertainty. You discuss with the patient, well, you could start a statin. I'm not sure how much it'll help, and that's not going to be satisfying to the patient. They're going to want to see more information. If they have plaque already developing, a calcium score can show that. So, and here it's talking about, okay, what we use with the scores themselves. So calcium score is 0. Say they're in that borderline risk category or maybe the lower intermediate risk. If it's 0, then that puts them into a new risk category and puts them lower risk because they don't even have any plaque that's built up yet. So you don't really need to start them on a statin. You can, if you have that, then the patient's still concerned, you can check it again in 5 years. If it's 1 to 99 or mild coronary atherosclerosis is what we call it, that favors the use of statin, especially after the age of 55. And then if it's above 100 or they're over 75th percentile for their age group, then it's highly recommended that you start statin therapy as well as an aspirin. So 1 to 99 is mild, 1 to 300 is moderate, and greater than 300 is severe. This is the software that we use to assess the calcific burden on the scan. Very easy to use. You can teach anybody to do this. Honestly, it's not very hard. You just click the plaque and you select what vessel it is, and it pumps out the number, gives you the percentile from the MESA database compared to people in their same age, race, and gender profile. And I'll say this again, because when you can get a calcium score of 0 for your patient with uncertain cardiac risk, very powerful and well-established fact that they are very low risk of having a cardiac event over the next 10 to 15 years. So I'm always thrilled when I can tell a patient that, because they're also very reassured that they're going to be fine. So it's continue healthy lifestyle. We don't necessarily need to start a statin yet, unless your total cholesterol is like above 300 or is exorbitantly high. Then I would still have that discussion. But in a kind of a more typical patient, this might spare them from starting a statin just yet. And so the U.S. guidelines, they suggest that when your calcium score is above 100, you start a statin. Also, like some global guidelines too, they also recommend starting a baby aspirin at that time as well, because you have an extensive plaque burden. Between 1 and 99 is a little controversial, and it's probably because we don't have great data to guide us yet, and I'm sure that will come. Here it says if it's 1 to 99 and less than 55 years, it says to hold the statin, reassess every 3 to 5 years. But that's like in the absence of considering their total cholesterol and their other risk factors. So if their total, their 10-year ASCVD risk score puts them in the intermediate risk category or borderline risk category, if the calcium score is between 1 and 99, I would still start them on a statin. So I kind of disagree with this, and it doesn't even have like a level of evidence behind that recommendation, which shows you the uncertainty behind that. And also, it's always going to be like an individualized patient discussion when you decide to start a statin or not. So you want to incorporate all the data you have. If your calcium score is 0, then you can withhold starting statin, maybe repeat a calcium score in 5 years. But if they have these other typical cardiac risk factors and they're very high risk, and right now they have no calcific plaque, but maybe in a year they will, because they have all these other risk factors, I would still start a statin in those patients. We have a lot of global guidelines, and then altogether, all the global guidelines very much agree that the calcium score 0, typically you can withhold statin, and above 100, you can initiate or consider starting a statin. Between 0 and 99, you want to just look at all the data you have for the patients and make a decision with the patient if they should start a statin or not. Okay, another example. 71-year-old Caucasian female with hypertension and high cholesterol, no prior history of heart attack, diabetes, or tobacco use, and no family history of coronary disease. Her cholesterol is a bit high. Her LDL is 173, but her HDL, good cholesterol, is high as well, so that's kind of be protective. But when you plug her numbers, her risk factor profile into that calculator, she falls into an intermediate risk category, having an event in the next 10 years, 16.6%. And like a lot of my patients hesitant to starting a statin resistant. So, we can actually see how much plaque is there. So we get a calcium score, and this is real. This patient had a calcium score of 0, and she's 71 years old, and that's very possible, and you can be really surprised. So yeah, this patient has high cholesterol, but that plaque, for lack of a better term, is not sticky. It's not adhering to the walls of the vessels, and it's not causing significant plaque burden that would put them at risk of a heart attack. So calcium score 0, they probably don't need to be considered for a statin at all for the rest of their life at age 71. So very helpful even in an older patient. So no statin started. Okay. Example 2, 62-year-old Caucasian female with a family history of premature coronary disease. Father had an MI age 71, just kind of older age for the parents, but 2 sisters had stents in their 50s. So kind of that's more premature than you'd expect. Otherwise, normal blood pressure, non-diabetic, non-smoker. Cholesterol panel looks pretty good overall. You plug those numbers into the risk calculators, 4.1%, that's a low risk category. But understandably, her sister's requiring stents at a younger age than her makes her pretty alarmed, and she's hesitant about some of the stuff she's heard about statins. So she wants to know if there's anything else we can do. Well, So we get a calcium score, and this falls into the moderate range, was above 100. She has a pretty dense plaque in her proximal LAD here. And then in another image, you would be able to see that there's a little speck of plaque in her circumflex as well. So in that case, is above 100, and I tell her like, you have plaque there. It's pretty significant, and if we don't get you on prevention now, that could land you in the same situation as your family members. And so she agreed to starting a statin at that time. So sometimes patients just need kind of a little more hard evidence because it's pretty abstract when you just tell them like, okay, the numbers, your cholesterol numbers are kind of borderline, but I still think you should be on a statin. It's easier to convince them when you have something real, tangible to show them. Last thing about calcium scores, the new thing about the guidelines, you can actually use these for patients with chest pain, but for the low risk patients, okay? The patients with no other risk factors might be in their 20s or their 30s, because that predictor of low cardiac events for the next 10 to 15 years with a score of 0 is incredibly useful. So the level of the classification of the recommendation is still 2A, so it's not super strong, but it's a reasonable thing to do. That your patients who are falling in the low risk category, you can do a calcium score instead of doing a treadmill stress test, say without imaging, as an option for these patients to kind of reassure them, okay, you have no plaque there or extensive plaque, because they might still have some soft plaque there. A calcium score does not pick that up. But a calcium score of 0 should be very reassuring that, okay, my arteries are okay. This might be chest pain that's caused by something else. So let's see here. I think starting to run out of time. So I'll just talk quickly about some other things we can use cardiac CT for. We use them for our TAVR patients. When you put in the percutaneous TAVR valve for patients who are post-surgical candidates for surgical aortic valve replacement. We always do a CT to get measurements of the annulus, or the kind of the lower plane of the aortic valve, and what size of a TAVR valve that would accommodate. Also, we use that to get dimensions of the aorta, or if there's extensive plaque that as you put the catheter up, that might break loose and cause a stroke. So that's really important. And also kind of the access size when you go into their femoral arteries. So all patients getting a TAVR always get a TAVR protocol CT. You can also use calcium score to quantify how much calcium is in the aortic valve. We do this for patients that have borderline severe aortic stenosis, or you just need a little more evidence to support this patient would benefit from getting a valve replacement or some sort of intervention. Sometimes we have patients where the valve looks really severe, but their velocities and gradients across the valve don't fall into that severe category. So everything's just kind of borderline. What could push you over the edge is if the valve is extensively calcified. And it's been shown that patients with a aortic valve calcium score over 2,000 or women over 1,300, that these have incremental prognostic value to the echo assessment. So if your echo measurements are borderline or inconclusive, you do a calcium score and it's extensively calcified, that is most likely severe. They should probably get a TAVR, or maybe they're a good surgical candidate as well. For our Watchman patients, usually, or Watchman, if you're not familiar with it, it's an option for AFib to get patients off anticoagulation, where we put in a left atrial appendage occluder and seals that off, and they're able to come off their blood thinner and still have similar stroke prevention after that's placed in. We usually do a transesophageal echo to size the appendage and also to check it afterwards to make sure it's sealed off before we make the decision for them to come off their Eliquis or Xarelto or warfarin. But a CT can give us the same information. Maybe they have a contraindication to getting a TEE. Maybe they have esophageal stricture, difficulty swallowing, history of bleeding. We can do the same information with the CT, but with the disadvantage of your exposure to the radiation and contrast. So it's not a perfect test for everybody. So, but we still do this here for some of our patients for our Watchman evaluations. And finally, congenital heart disease. There's a huge spectrum of congenital heart disease, and at our center, kind of in our adult cardiology realm, don't really see too many CTs ordered for this reason. I saw them a lot in fellowship, but what's awesome about this compared to echo is that you get a full kind of high resolution 3D data set. They can manipulate the planes and see the heart from all these different angles and really get a good idea, as well as a 3D post-processing reproduction of the structure of the heart that can tell you what's connecting where. Because sometimes from an echocardiogram, you're just given a certain set of images and you can't really get an idea where things are connecting, and you can be very inconclusive in your echo reporting. But the CT can help kind of clarify things. This is partial anomalous pulmonary venous return, meaning that the pulmonary vein, instead of connecting to the left atrium, is connecting to the right atrium. Usually that's associated with a secundum atrial septal defect, or like a connection between the right and left atrium. Tough to pick up on a transthoracic echo, and sometimes it can be even missed on transesophageal echo. So if you have a patient with like a big RV and you can't explain it, maybe a CT scan might uncover a congenital lesion that's been undiagnosed for years. So, all right, that's it. Any questions?
Dr. Stone, I have a question. This is Drew. Do you collect LP little a's and like family history? Since it's not part of the score, does it impact how you make your decisions?
Yes, for sure. I check LP little a quite often. That's lipoprotein A. That's for everybody. It's a kind of a factor that assesses kind of the stickiness of that plaque, or how atherosclerotic it is. Because you can have kind of an elevated cholesterol, but like that 70-year-old lady that I had before that had a calcium score of 0, I bet her LP little a would be normal. But you have a patient with a strong family history, maybe their calcium score is 0. And LP little a would be very helpful in that case, because if you get that and that's abnormally high, then they're at risk for developing early atherosclerosis. So that's where I kind of fit that into lab panel. If a patient comes and they have a very clear early family history, a lot of times the older calcium score and the LP little a in addition to their lipid panel. So it should be kind of not in your routine assessment for patients. Like everybody should get a lipid panel like each year in their adulthood, basically. But if you just need a little more risk stratification data, LP little a is very helpful, as well as a calcium score. So a calcium score of 0 is great, but an LP little a that's abnormal might push them into more of that concerning intermediate risk category. So that's why I incorporate that lab. But unfortunately, when you have an LP little a that's high, that stays high for all your adult life, they're investigating treatments right now that might lower that. But we don't have anything right now that specifically targets that.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.